Hello, this is Dr. Adam Boxer from the University of California in San Francisco. Welcome to this educational infographic-based activity on progressive supranuclear palsy.
The following podcast is part of a certified educational activity titled Progressive Supranuclear Palsy, Examining Diagnostic Considerations and Emerging Treatment Approaches. Access the entire activity and complete the post-test at peerview.com/YPK860. Downloadable infographics and additional resources are also available.
Progressive supranuclear palsy, or PSP, is often considered to be the prototypical neurodegenerative tauopathy. It was named based on the clinical features that were noted by a very astute neurologist who practiced in Toronto, J. Clifford Richardson, in a seminal manuscript that was published in the Archives of Neurology in 1964. Dr. Richardson, who worked with a neuropathologist, Dr. Olszewski, and a fellow, Dr. Steele, described the first 3 cases that they saw clinically with this syndrome. These cases were then followed to autopsy, and the distinctive neuropathology that we now know to underlie progressive supranuclear palsy was associated with these cases. I will now show a video describing the 3 original cases that Dr. Richardson saw and Dr. Steele and Dr. Olszewski then studied as they came to autopsy. The individual who is speaking in the video is Dr. John Steele, who was the first author of the manuscript, which is entitled Progressive Supranuclear Palsy, a Heterogeneous Degeneration Involving the Brainstem, Basal Ganglia, and Cerebellum with Vertical Gaze and Pseudobulbar Palsy, Knuckle Dystonia, and Dementia.
In the 1950s, in Toronto, neurologist Clifford Richardson identified an unusual disease whose hallmark was progressive supranuclear gaze palsy. His first patient, a Canadian executive, could follow to either side through a full range. This film was made in 1959 when the patient was 56 years of age. At this time, the face was spastic. He was dysarthric. He could not look up and down, and he was quite unable to follow Dr. Richardson's pen moving slowly in the vertical plane. But when his head was passively flexed and extended, his eyes moved through a full range reflexly in the opposite direction as occurs when a doll's head is similarly positioned. Here he is attempting to look down at his watch, but as you see, he is unable to do so. When his neck is flexed, however, his eyes deviate up and he cannot move them down. Richardson's second case was an English immigrant and a truck driver. His gait was slow and unsteady, and there was considerable axial extension. Here you see his difficulty in searching and picking an object from the chair because he cannot look down and his neck is extended. He has a very stiff spastic face, marked dysarthria, and a prominent vertical gaze palsy with preservation of oculocephalic reflexes. Richardson's third case was a Ukrainian laborer and a veteran of World War I. By 1958, when aged 66, his walking was slow and awkward, and he had particular difficulty in truncal movement, suggesting an apraxia. Here we see a tendency to reel and fall backwards when rising and walking. Notice his spastic, upturned face and neck, very prominent blepharospasm, and the marked limitation of following movements of the eyes in both the vertical and horizontal planes.
So these were 3 of the original cases that were analyzed by Drs. Steele, Richardson, and Olszewski. And really, this is the classic PSP syndrome that has been since renamed Richardson syndrome, or PSP Richardson syndrome, really to give credit to J.C. Richardson, who was the critical neurologist who described these patients and really noticed that they were different from people who had typical Parkinson's disease. This is not the first description, however, of the classic PSP Richardson syndrome. This is a quote from Charles Dickens in one of his books in 1857 from The Lazy Tour of Two Idle Apprentices by Dickens and Collins. And this is the perfect description of Richardson syndrome. A chilled, slow, earthy fixed man, so that's the bradykinesia, a cadaverous man of measured speech, a man who seemed as unable to wink as if his eyelids had been nailed to his forehead. So there's the supranuclear gaze palsy. A man whose eyes, two spots of fire, had no more motion than if they had been connected with the back of his skull by screws driven through them and riveted and bolted outside amongst his gray hair. He had come in and shut the door, and he now sat down. He did not bend himself to sit, as other people do, but seemed to sink bolt upright, as if in water, until the chair stopped him. So here's the other key feature of PSP Richardson syndrome, which is the gait instability and falls, which often is also manifested in difficulty sitting down. It's often possible to diagnose someone across the waiting room just based on their appearance of their face, their inability to move their eyes, and their gait instability. This is a schematic of the neuropathology associated with PSP. We now recognize that the key protein or molecule that's deposited in the brain of patients with Richardson syndrome who come to autopsy is a protein called tau. And it's deposited in both neurons in the form of globose tangles that you see here on the left, but also in glia. One of the characteristic glial deposits is called the tufted astrocyte, and here is an immunohistopathology picture of one of these astrocytes stained for tau. What we now know about Richardson syndrome is that the amount and the extent of tau pathology really is related to both the disease severity and the types of symptoms that people have during life. So you can see there are areas in the brainstem and later in the course of the disease in the cortex where there's really a large amount of insoluble tau that's deposited. And this goes along with what you would see in these end-stage patients with PSP who are demonstrated in the video I showed you earlier. So, as we've learned more about the tau gene, we understand that it's a very important component of many types of neurodegenerative disease. But particularly for PSP, it's very closely linked genetically as well as neuropathologically to the disease. So here you can see a schematic of the DNA structure of the tau gene. And what you see beneath this are the different types of proteins that are generated from this alternatively spliced gene. Tau is known to be a protein that binds to structures in neurons called microtubules that gives these cells structure and, for instance, allows these cells to extend axons to meet other neurons. And you can see in the top three isoforms, there are three microtubule binding domains. They're called 3R tau. And in the bottom three forms of the gene, there are four microtubule binding domains, and these are called 4R tau, or 4-repeat tau. And these different forms of tau protein are generated from alternative splicing of a number of exons. Importantly, there are certain mutations that lead to overproduction of 4-repeat tau. So these 4R tau proteins at the bottom, and these mutations are frequently in or around intron 10. We also know from studies called genome-wide association studies that the strongest genetic links to PSP are in and around the tau protein gene. One example is called the H1 haplotype, and when people are homozygous for the H1 tau haplotype, their odds ratio of getting PSP is 5.46 relative to people who have only one H1 allele, with a p-value of 10 to the negative 116th. We also know that there are other genetic links to tau that are strong risk factors for PSP. Typical PSP Richardson syndrome is a primary sporadic 4-repeat tauopathy because at autopsy, most of the tau that is deposited is primarily 4-repeat tau. In a normal brain or in a brain that has Alzheimer's disease, there is an equal ratio of 3-repeat to 4-repeat tau. So for some reason, there's a strong genetic link to 4-repeat tau in PSP, and this is why many therapies that are being developed for PSP are focusing on the tau gene, and in particular on this 4-repeat type of tau. So another video of a retired psychology professor.
Put out your tongue. And blow out a match.
Blow out a match. Right.
Make a fist. And salute. Wave goodbye. And use a comb.
Use a comb.
Use a key.
Key. use a key.
Or just pretend to.
Right. And
Yeah. And pretend to light a cigarette.
pretend to light a cigarette. And I forget how it's been 14 years since I was off.
That was an example of another clinical presentation of progressive supranuclear palsy that we call Nonfluent Variant Primary Progressive Aphasia, also with features of something called corticobasal syndrome. You can see that the patient has a lot of trouble making the mouth movements to pantomime blowing out a match, and that's called orobuccal apraxia. As you listen to his speech, it's very effortful, interrupted, and apractic, and that's called an apraxia of speech. And you can see that the individual has a lot of trouble pantomiming movements like waving or combing, and this is called an ideomotor apraxia of limb movement. When you see someone who has Richardson syndrome that I showed you in the first video, they display those symptoms of eye movement abnormalities, falls, axial rigidity, and bulbar symptoms. There may also be cognitive problems as well as behavioral problems. Almost all of these patients, in some studies approaching 100% of them, will have the classic neuropathology associated with PSP, which is primarily 4-repeat tau deposition and neuronal loss distributed in that pattern. But what we've learned over the years is that there are people who sometimes have other clinical syndromes, and some of these patients also will have a syndrome that looks like typical Parkinson's disease that eventually begins to look more like Richardson syndrome. Others will have something that's primarily a gait freezing disorder called pure akinesia with gait freezing. Some patients will present with a behavioral syndrome, so progressive non-fluent aphasia, or even rarely a frontotemporal dementia, which is mainly a behavioral and cognitive syndrome. But over the years, they start to change and begin to look more like typical Richardson syndrome. Often, we can't know that their underlying pathology is PSP until they seem to show symptoms of the PSP-Richardson syndrome. Increasingly, it's also recognized that even people with Richardson syndrome often have other prodromal symptoms, such as psychiatric symptoms, depression, and withdrawal, or dysexecutive symptoms that may predate the onset of the movement disorder. These different clinical presentations of PSP are reflected in new PSP diagnostic criteria that were published in 2017 by the International Movement Disorders Society's PSP Working Group. And here, we recognize that likely there are some people who have PSP pathology in their brain, but no clinical symptoms yet, because it's not yet severe enough to cause any sort of movement, behavioral, or cognitive problems. Some of these people actually will have very mild pathology that never progresses enough to develop the disease. We also recognize that there are some people who have this mild pathology, but it starts to get worse, and they have mild symptoms that are suggestive of PSP, but not sufficient to make that clinical diagnosis. Some of these people may have isolated gait instability or isolated eye movement abnormalities, but they never actually progress to the full-blown PSP-Richardson syndrome. We call that suggestive of PSP. Many of these people will develop the full Richardson syndrome and die from usually swallowing difficulties, aspiration, or falls. But we also recognize that people will often develop a variant syndrome, but over the years they develop more symptoms of the classic PSP-Richardson syndrome. So, to attempt to make it easier to diagnose these other variant forms, we now look at 4 functional domains when we make the diagnosis of these different PSP syndromes. We look at the degree of ocular motor dysfunction, the degree of postural instability, the degree of akinesia, and the degree of cognitive dysfunction. And the new diagnostic criteria use a combination of these different levels of certainty to diagnose the different variant forms of PSP. So it's through recognition of these different clinical PSP symptoms that we can diagnose the full spectrum of clinical features of PSP using the new criteria. Many people are interested in developing biomarkers, and one interesting thing is that although we recognize that PSP is very strongly related to tau pathology and to the genetics of tau, when we look at the cerebrospinal fluid tau levels from a variety of published studies, often PSP patients have normal or slightly low levels of tau protein as compared with normal controls. And the relationship between spinal fluid levels of tau and disease is complicated and not clearly related to whether something has underlying tau pathology, because Alzheimer's patients have high levels of tau, but patients with PSP have normal or slightly low levels of tau, as you can see in the right panel. What we know, however, is that there are other fluid biomarkers that are useful in PSP. What you can see in the right panel is that neurofilament light chain level, or log-NFL, is strongly related to the rate of progression on this rating scale over time. Some patients with low levels of neurofilament have the slowest or most indolent course of disease, but those with higher levels have a much more rapid progression of disease and attain high levels on the PSP rating scale over a year. Interestingly, if we look at the phosphorylated tau levels in the spinal fluid, there's the opposite relationship, and this suggests that the degree of suppression of phosphorylated tau levels in the CSF of PSP patients must in some way be related to the disease pathology. This is an active area of research. Recently, the technology has been developed to measure neurofilament in the blood, and you can also measure elevated neurofilament levels in PSP. So in the left panel, you can see patients with PSP at baseline and then after a year have elevated blood levels of neurofilament light chain as compared with age-matched controls. So those patients who have high blood levels of neurofilament will have a slightly faster rate of progression on motor scales, on activities of daily living, and also a much worse progression of their cognitive dysfunction as compared to patients who have low levels of neurofilament in the blood. So in the future, we expect that when neurofilament light chain becomes a clinically available test, it's not currently available for clinical use, it'll be useful in helping to stage patients with PSP. Here you see structural MRI images from a patient with PSP Richardson syndrome. What you can note on the left is a classic sign on MRI called the hummingbird sign. If you look at the midbrain at the top center, it looks like the head of a hummingbird with the pontine tegmentum looking a bit like the wings of a hummingbird. The reason why the midbrain looks like the head of a hummingbird is because it is decreased significantly in volume in PSP, and this is considered to be a supportive diagnostic sign of PSP. It's not specific for the underlying PSP pathology, but when you have Richardson syndrome, this imaging feature, as well as the morning glory or Mickey Mouse sign on the right, which also reflects midbrain volume loss, is often present. There are a number of NIH-funded longitudinal natural history studies of PSP patients. One is called the 4-Repeat Tauopathy Neuroimaging Initiative. Through studies like this, we are learning about other biomarkers that may help us to understand and characterize disease progression in PSP. So during the initial stages of the 4-Repeat Tauopathy Neuroimaging Initiative, patients were studied every 6 months with MRI scans, clinical evaluations, eye movement evaluations, and different blood and CSF markers. And what's been recognized is that in PSP, there are very characteristic patterns of brain atrophy. This is actually something that you can visualize on a standard MRI scan, but here we see statistically significant areas of brain atrophy in PSP Richardson patients. What you can see is that even after 6 months, there is highly significant atrophy in the midbrain and pontine areas, and this is reflected in that hummingbird sign that I showed you earlier. After another 6 months, you can see that the extent of this atrophy gets worse and more severe. We can actually quantify the volume of these brain regions using computational measures of volume on a standard T1 weighted volumetric MRI. And so, for instance, we can quantify the volume of the midbrain or the left precentral gyrus. Here you can see that if we follow the volume of the midbrain in healthy controls, there really isn't much of a change over 12 months. But in patients with PSP, in either the 4-repeat tauopathy population or a clinical trial, you can see that there's really quite significant volume loss. A little over 2% of the volume of the midbrain is lost over the course of a year in PSP. And this strongly correlates with the symptoms that we see, the falls, the eye movement changes, etc. There are also changes in the volume of the cortical regions. You can see that as compared to the blue line, there is atrophy in the precentral gyri, but it's less prominent than what we would see in the midbrain. If we look at another clinical presentation of PSP, one that is called corticobasal syndrome in green, you can see in that clinical presentation there is more severe atrophy of these cortical regions over time. There's also great interest in developing PET ligands that can bind to tau protein. And here's an example of some initial studies with a PET ligand called fluortaucipir. So this is fluortaucipir PET and PSP versus patients with typical Parkinson's disease. What you can see is that in these areas that we know to be involved with PSP pathology, the basal ganglia, midbrain, and the deep nuclei of the cerebellum, there's elevated fluortaucipir uptake in PSP as compared with normal controls in the top panel, and as compared with patients who have similar levels of motor disability with Parkinson's disease. Subsequent work with fluortaucipir suggests that some of these findings may not be specific to tau protein, and so people are now looking for better ligands that could be used to characterize PSP patients. There are also very striking abnormalities in sleep. This is some work that was done by actigraphy that shows changes in circadian rhythms and sleep that occur in PSP patients when you have them wear a wrist actigraphy watch for a week. So you can see in the control patients, there's an example of a control individual in the left panel, and you can see that each of these lines is 24 hours. So you can see in green that there's a lot of movement when the patient is awake, and then it becomes black when they're sleeping. You can see that there are pretty regular patterns in the control individuals over the course of these measurements, whereas on the right, you can see in the PSP patients that there's much less of a delineation in the circadian rhythms. And this really reflects a severe deficit in sleep in patients with PSP. You can see that the degree of disruption of these circadian rhythms, which is measured by mesor counts per minute, is actually correlated with their motor disability on the PSP rating scale. And it's thought that this really distinctive sleep and circadian rhythm disorder in PSP may contribute to patients' disability. So currently, there are no FDA-approved treatments for patients with PSP, and almost all patients who develop a PSP syndrome will die of PSP, particularly if it's Richardson syndrome. Although there are no disease-modifying strategies for PSP, there are some strategies that have been used that help with symptoms. So some patients with PSP actually will respond to levodopa. Usually the response is less than what you would see in typical Parkinson's disease. Many of these patients will have a variant presentation of PSP called PSP Parkinsonism, and in that case, they initially look like they have idiopathic Parkinson's disease, but then over time they begin to develop more symptoms of Richardson syndrome. A small number of patients who have severe difficulty with opening their eyes due to apraxia of eyelid opening will respond to botulinum toxin injections in the pretarsal muscles. This is sometimes helpful, but not helpful for all patients. And what seems to actually be the most beneficial for patients with PSP is intensive physical, occupational, and speech therapy. There was a clinical trial that was done in Italy a few years ago that showed that a month of intensive rehabilitation therapy actually led to significant improvements on the PSP rating scale, which is primarily a motor scale on PSP. A small trial that was done over 6 months initially showed a very modest benefit on the PSP rating scale with coenzyme Q10 supplementation. A longer 1-year trial failed to replicate that benefit. However, in examining the data, there was a suggestion that possibly there might be a small benefit from coenzyme Q10. And so although it is not approved by the FDA, sometimes patients will take coenzyme Q10 supplementation if they have PSP. This image suggests that there are a variety of experimental strategies that one might adopt to ameliorate the tau pathology or the effects of this tau pathology in PSP patients. So one general class of interventions that have not yet really reached the clinic in PSP is to affect the gene expression of tau to try and reduce its expression or change the splicing of the tau protein gene. But there are a variety of therapies that have been tested that address the loss of normal tau function. And recall that tau is thought to have an important function in stabilizing microtubules. So it's thought that in patients with PSP, microtubules may not function normally. More commonly, the current research community believes that the cause of neurodegeneration, more likely in PSP and other tauopathies, is due to toxic gain of function. And that may be through aggregation of tau into those insoluble deposits and possibly what's called a prion-like spread of tau. So it's possible that the aggregates may form in one cell, and then they template other forms of tau that will then spread to neighboring neurons and glia, and that may be how the disease spreads. So you see examples of 2 drugs that were tested in the past and were thought to make up for loss of tau function. Again, these drugs were both thought to stabilize microtubules. One was called davunitide, and the other is a derivative of the anti-cancer drug paclitaxel called TPI-287. Neither of these trials found that these tau loss of function therapies were efficacious in stabilizing disease progression, and further work with davunitide and TPI-287 has not been pursued. This has added to the impression that tau loss of function may not be the key problem in PSP. This is an example of the data from the davunitide trial showing that when approximately 150 patients in the davunitide treatment group were compared with approximately 150 patients in the placebo group, there really was no difference in the rate of disease progression on the motor rating scale, the PSP rating scale, or the Schwab and England activities of daily living scale. But what you can see is that all of these patients really declined quite severely over the course of 1 year. Currently, there are a number of clinical trials going on with monoclonal antibodies to tau protein. Two of the antibodies that are in large international phase 2 clinical trials are listed here. One is called BIB92 and the other is called ABBV8E12. Hopefully, by the end of 2019 or 2020, we will get some results from these clinical trials and understand whether this approach to reducing toxic gain of tau function may be effective for PSP. We also believe that there may be other approaches that are targeting this toxic gain of tau function that will be pursued for PSP, but those clinical trials are not yet underway. In conclusion, progressive supranuclear palsy causes a spectrum of motor, cognitive, and behavioral syndromes. The classic syndrome that people used to call PSP, we now call PSP-Richardson syndrome. And these patients have characteristic difficulties with eye movement, called a gaze palsy, and they have gait instability and falls. Over the years, it's been recognized that there are other clinical presentations of PSP, and the new 2017 Movement Disorder Society PSP Diagnostic Criteria expand the clinical spectrum of PSP by defining these variant PSP syndromes or phenotypes like Nonfluent Variant Primary Progressive Aphasia or Corticobasal Syndrome. There are currently no effective or FDA-approved therapies for PSP, but there are some symptomatic strategies that help people to have a better quality of life. Physical therapy seems to be particularly helpful in this regard. There is great hope that based on our understanding of the biology and the neuropathology and genetics of PSP, that we may be able to develop new disease-modifying therapies. The current thinking is that if we can reduce the amount of toxic forms of tau or reduce their spread in the brain or possibly compensate for the loss of normal tau function, this may be a way that we can hopefully slow disease progression and hopefully eventually cure PSP. Thank you for your attention.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/YPK860. This activity is supported by an educational grant from Biogen.